Good morning. Welcome to the North London Social Work Teaching Partnerships online training programme. Today's session is on addiction and personality disorder, and my name is Cherie Carlton. I'm a social work lecturer in practice at Middlesex University. I'm a social worker by discipline with experience of working in both adult and children's social work. What we'll hope to cover during this webinar is having a bit of a conversation about personality disorder and addictions, thinking about the kind of concepts themselves and the stigma attached to those diagnoses. Have a bit of a think about the bio-psychosocial perspectives, how personality disorder and addictions come into play. What are the factors that influence the onset of those disorders, or what's the current thinking? Having a bit of a think about whether there are commonalities or synergies between those, the causes to those conditions, for want of a better term. And having a bit of a think about what the dilemmas are in engaging those populations who attract those diagnoses. And have a bit of a think about how we might approach engaging individuals who have symptoms that or experiences that are consistent with personality disorder or addictions more effectively. And I guess I'll invite us to have a think about trauma-informed approaches to working with people who have high levels of distress. Great. So defining the concepts. What I'm quite keen to think about is what the first words or kind of concepts that come to mind when you think about the term personality disorder or addictions. And I'll ask for those of you who are already engaging to post your comments or chat. Just to say that those comments are private, so people won't see those comments that you're requesting or sharing. But it would be useful to get some kind of views about where did your ideas come from? Where did they come from? What's the first thing that comes to mind when you think about those terms? Don't think about it too hard, just the first thing that comes to mind. That would be great. When we've started to think about some of the terms, the first kind of concepts that come to mind, I'd like us to have a bit of a moment of reflection about where those ideas come from. I think it's fair to say that, there's quite a bit of synergy in terms of the kind of comments that people are posting, and I'm not going to go into individuals, but the kind of themes that are coming across are that there's a real sense of challenge in engaging people who have these diagnoses, that actually there's a component of which there's an antisocial nature to the behaviours that we might identify. That actually it's a real interpersonal sense. It's a real sense of interpersonal attributes that we're thinking about, the relationship with other people and difficulties with that. So I think that's quite an interesting point to start with, that we're thinking about an interpersonal issue. So it's about the way that we're relating to each other. When we think about that, and we think about that in relation to personality disorder particularly, we all have a personality, and a personality is defined as a kind of way of thinking and being, really. So our patterns of thinking and behaviour that make up our personality, and that this can be often changeable over a period of time. We're not the same person that we were earlier in our lives, And often people's personality evolves in response to their circumstances and their environment. And if we've got a good basis to begin with, I think it's fair to say that we are able very early on to relate with others and respond to interactions with others. So when we think about personality disorder, the diagnosis itself feels like a very personal kind of thing, really, and it makes it quite a challenge to think about how one might experience receiving a diagnosis. And the difficulty, I guess, with the kind of concept of personality disorder is that we're arguably saying that people have difficulties with their ability to relate to other people. But, personality is a central part of who we are. So it's as much as saying our personhood is flawed. It's true to say that people who attract the diagnosis of personality disorder often have difficulties interacting with other people, and particular difficulties with relation to relationships, understanding and responding to social interactions and social cues, and that can be quite a challenge to engage with people in that respect. When it comes to personality disorder as a diagnosis, in order to attract the diagnosis of personality disorder, the kind of patterns of difficulty have to be persistent and have to have happened over a period of time, and they can't be as a result of substance use or other conditions. Quite often, those experiences are traced back to much earlier in life, early adulthood, and commonly you will see for people who have some of these disorders, they would have engaged with child and adolescent mental health services earlier on. Particularly those with antisocial behaviour often attract diagnoses of conduct disorder early on. And the manifestation of these experiences or these symptoms continue to cause significant distress or have really adverse consequences in a range of areas in a person's life. When we think about personality, we think about personality traits, and there are a spectrum of traits and a spectrum of intensity of those traits, and I think it's important that we recognise that these are not binary concepts in and of themselves. What we do know, however, is that people who attract these diagnoses often have real difficulties in relation to their sense of self, their ideas of who they are, difficulties in relation to their self-image, their relationships with others, have a real challenge in regulating and managing their emotions, and often have real challenges with regards to impulse control. Understanding the origins of these difficulties can be hard because, thinking about how people come to have a disordered personality or to have the kind of core of themselves not functioning in terms of wellness can be a real challenge. And I think largely it's been explained by the bio-psychosocial models and perspectives. And I think that fits really well in encapsulating the varying components of well-being. I think when it comes to personality disorder, particularly if we look at that through the bio-psychosocial model, you might consider that a person is born with particular vulnerabilities, genetic predispositions, or factors that have occurred in utero, so prenatal factors, combined with perhaps experiences of abuse or maltreatment during early childhood. And there's certainly much more thinking around attachment and trauma, and I know that many of you mentioned that in your comments, but that trauma, particularly adverse childhood experiences, might lend themselves to be influential. And the social factors, whether those be contributing factors, so non-supportive environments, living in hostility, or not being kind of accepted, socially excluded, versus those kind of protective factors. And the reality is with the bio-psychosocial perspectives is that it's not a direct causal, there's not one singular causal link, that the suggestion is that these are multifactorial influences. And I think that these influences might be overlaid in terms of thinking also about the origins of addictions. What you'll see here is a kind of a pathway illustrating the biopsychosocial model of personality disorder, and this is generally seen to be in relation to people with a borderline personality disorder, though the commonalities are obviously illustrated in personality disorders of all forms. And I think it's interesting to think about the range of personality disorders in terms of diagnoses. Things like the emotionally unstable, borderline type personality disorder, the antisocial personality disorders, as well as, other rarer types of disorders, paranoid or histrionic type diagnoses. And thinking about how the biopsychosocial model might respond to those sorts of presentations, whether the biological or genetic vulnerabilities and the psychological stresses are the same or perhaps different in terms of how those experiences are manifested, or whether in fact they're the same. And I think when we think about the commonalities and the differences of influence, I think it's really important from a social work perspective. I'm certainly much more minded to think about the psychological and social factors that influence the onset of difficulties or distress. But that's notwithstanding the fact that there's a lot of evidence that suggests that certainly prenatal factors and genetic vulnerabilities are at play for some people some of the time. Going to move us on through to thinking about theories of addiction. I think one of the interesting things about the theories of addiction is that there are two kind of main theories, and those are that addictions are a disease. So the nature theory, or that these are socially learned behaviours, and perhaps much more inclined towards the nurture theory. I think both come with an interesting influence, because in many respects the disease theory kind of takes away from the moral implications of a social learning of choice, and can be offer some kind of validation for people in their experiences. But I think it doesn't necessarily give entirety some weight to the kind of lived experiences and the influence of that. What I would like us to do is to take some time having a look at this video clip and having a think about whether or not this fits with some of your ideas around the origins of addiction.
One of my earliest memories is of trying to wake up one of my relatives and not being able to. And I was just a little kid, so I didn't really understand why. But as I got older, I realized we had drug addiction in my family, including later cocaine addiction. I've been thinking about it a lot lately, partly because it's now exactly 100 years since drugs were first banned in the United States and Britain, and we then imposed that on the rest of the world. It's a century since we made this really fateful decision to take addicts and punish them and make them suffer because we believed that would deter them, it would give them an incentive to stop. And a few years ago, I was looking at some of the addicts in my life who I love and trying to figure out if there was some way to help them. And I realized there were loads of incredibly basic questions I just didn't know the answer to. Like, what really causes addiction? Why do we carry on with this approach that doesn't seem to be working? And is there a better way out there that we could try instead? So I read loads of stuff about it, and I couldn't really find the answers I was looking for. So I thought, okay, I'll go and sit with different people around the world who've lived this and studied this and talk to them and see if I can learn from them. And I didn't realize I would end up going over 30,000 miles at the start, but I ended up going and meeting loads of different people, from a transgender crack dealer in Brownsville, Brooklyn, to a scientist who spends a lot of time feeding hallucinogens to mongooses to see if they like them. It turns out they do, but only in very specific circumstances. To the only country that's ever decriminalized all drugs, from cannabis to crack, Portugal. And the thing I realized that really blew my mind is almost everything we think we know about addiction is wrong. And if we start to absorb the new evidence about addiction, I think we're going to have to change a lot more than our drug policies. But let's start with what we think we know, what I thought I know, right? Let's think about this middle row here, right? Imagine all of you, for 20 days now, went off and used heroin 3 times a day. Some of you look a little bit more enthusiastic than others at this prospect. Don't worry, it's just a thought experiment. Imagine you did that, right? What would happen? Now, we have a story about what would happen that we've been told for a century. We think because there are chemical hooks in heroin, as you took it for a while, your body would become dependent on those hooks, you'd start to physically need them, and at the end of those 20 days, you'd all be heroin addicts, right? That's what I thought. First thing that alerted me to the fact something not right with this story is when it was explained to me, if I step out of this TED Talk today and I get hit by a car and I break my hip, I'll be taken to hospital and I'll be given loads of diamorphine. Diamorphine is heroin. It's actually much better heroin than you're ever going to buy on the streets, because the stuff you buy from a drug dealer is contaminated, actually very little of it is heroin, whereas the stuff you get from the doctor is medically pure. And you'll be given it for quite a long period of time. There are loads of people in this room who may not realize that you've taken quite a lot of heroin, right? And anyone watching this anywhere in the world, this is happening. And if what we believe about addiction is right, those people are exposed to all those chemical hooks. What should happen? They should become addicts. This has been studied really carefully. It doesn't happen. You will have noticed if your grandmother had a hip replacement, she didn't come out as a junkie. And when I learned this, it just seemed so weird to me, so contrary to everything I'd been told, everything I thought I knew. I just thought it couldn't be right. Until I went and met a man called Bruce Alexander, who's a professor of psychology in Vancouver, who carried out an incredible experiment that I think really helps us to understand this issue. Professor Alexander explained to me, the idea of addiction we've all got in our heads, that story, comes partly from a series of experiments that were done earlier in the 20th century. They're really simple experiments. You can do them tonight when you go home if you feel a little bit sadistic. You get a rat and you put it in a cage, and you give it 2 water bottles. One is just water, and the other is water laced with either heroin or cocaine. If you do that, the rat will almost always prefer the drugged water and almost always kill itself quite quickly. So there you go, right? That's how we think it works. In the 70s, Professor Alexander comes along and he looks at this experiment and he noticed something. He said, we're putting the rat in an empty cage. It's got nothing to do except use these drugs. Let's try something a bit different. So Professor Alexander built a cage that he called Rat Park, which is basically heaven for rats, right? They've got loads of cheese, they've got loads of colored balls, they've got loads of tunnels. Crucially, they've got loads of friends, they can have loads of sex, and they've got both the water bottles, the normal water and the drugged water. But here's the fascinating thing. In Rat Park, they don't like the drugged water. They almost never use it. None of them ever use it compulsively. None of them ever overdose. You go from almost 100% overdose when they're isolated to 0% overdose when they have happy and connected lives. Now, when he first saw this, Professor Alexander thought, maybe this is just a thing about rats. They're quite different to us, maybe not as different as we'd like, but, But fortunately, there was a human experiment into the exact same principle happening at the exact same time. It was called the Vietnam War. In Vietnam, 20% of all American troops were using loads of heroin. And if you look at the news reports from the time, they were really worried because they thought, my God, we're going to have hundreds of thousands of junkies on the streets of the United States when the war ends. It made total sense. Now, those soldiers who were using loads of heroin were followed home. The Archives of General Psychiatry did a really detailed study, and what happened to them? It turns out they didn't go to rehab. They didn't go into withdrawal. 95% of them just stopped. Now, if you believe the story about chemical hooks, that makes absolutely no sense. But Professor Alexander began to think there might be a different story about addiction. He said, what if addiction isn't about your chemical hooks? What if addiction is about your cage? What if addiction is an adaptation to your environment? Looking at this, there was another professor called Peter Cohen in the Netherlands who said, maybe we shouldn't even call it addiction. Maybe we should call it bonding. Human beings have a natural and innate need to bond. And when we're happy and healthy, we'll bond and connect with each other. But if you can't do that because you're traumatized or isolated or beaten down by life, you will bond with something that will give you some sense of relief. Now, that might be gambling, that might be pornography, that might be cocaine, that might be cannabis, but you will bond and connect with something because that's our nature. That's what we want as human beings. And I think, at first I found this quite a difficult thing to get my head around, but one way that helped me to think about it is, and I can see, I've got over by my seat there a bottle of water, right? I'm looking at lots of you, and lots of you have bottles of water with you, right? Forget drugs, forget the drug war. Totally legally, all of those bottles of water could be bottles of vodka, right? We could all be getting drunk, I might after this. But we're not, right? Now, because you've been able to afford the approximately £1 gazillion that it costs to get into a TED Talk, I'm guessing you guys could afford to be drinking vodka for the next 6 months. You wouldn't end up homeless. You're not going to do that. And the reason you're not going to do that is not because anyone's stopping you. It's because you've got bonds and connections that you want to be present for. You've got work you love. You've got people you love. You've got healthy relationships. And a core part of addiction, I came to think, and I believe the evidence suggests, is about not being able to bear to be present in your life. Now, this has really significant implications. The most obvious implications are for the war on drugs, right? In Arizona, I went out with a group of women who were made to wear T-shirts saying I was a drug addict and go out on chain gangs and dig graves while members of the public could jeer at them. And when those women get out of prison, they're going to have criminal records that mean they'll never work in the legal economy again. Now, that's a very extreme example, obviously, in the case of the chain gang, but actually almost everywhere in the world we treat addicts to some degree like that. We punish them, we shame them, we give them criminal records, we put barriers between them reconnecting. There was a doctor in Canada, Dr. Gabor Mate, an amazing man, who said to me, if you wanted to design a system that would make addiction worse, you would design that system. Now, there's a place that decided to do the exact opposite, and I went there to see how it worked. In the year 2000, Portugal had one of the worst drug problems in Europe. 1% of the population was addicted to heroin, which is kind of mind-blowing. And every year, they tried the American way more and more. They punished people and stigmatized them and shamed them more. And every year, the problem got worse. And one day, the Prime Minister and the leader of the opposition got together and basically said, look, we can't go on with a country where we're having ever more people becoming heroin addicts. Let's set up a panel of scientists and doctors to figure out what would genuinely solve the problem. And they set up a panel led by an amazing man called Dr. João Goulão to look at all this new evidence. And they came back and they said, decriminalize all drugs, from cannabis to crack. But, and this is the crucial next step, take all the money we used to spend on cutting addicts off, on disconnecting them, and spend it instead on reconnecting them with the society. And that's not, essentially, that's not really what we think of. What they did wasn't really what we think of as drug treatment in the United States and Britain. So they do residential rehab, they do psychological therapy that does have some value. But the biggest thing they did was the complete opposite of what we do. A massive program of job creation for addicts and microloans for addicts to set up small businesses. So say you used to be a mechanic. When you're ready, they go to a garage and they'll say, if you employ this guy for a year, we'll pay half his wages. The goal was to make sure that every addict in Portugal had something to get out of bed for in the morning. And when I went and met the addicts in Portugal, it's fascinating. What they said is, as they rediscovered purpose, they rediscovered bonds and relationships with the wider society. It'll be 15 years this year since that experiment began, and the results are in. injecting drug use is down in Portugal, according to the British Journal of Criminology, by 50%, 50%. Overdose is massively down. HIV is massively down among addicts. Addiction in every study is significantly down. One of the ways you know it's worked so well is that almost nobody in Portugal wants to go back to the old system. Now, that's the kind of political implications. I actually think there's a layer of implications to all this research below that. You know, we live in a culture where people feel really increasingly vulnerable to all sorts of addictions, whether it's to their smartphones or to shopping or to eating. You know, before these talks began, you guys know this, that we were told we weren't allowed to have our smartphones on. And I have to say, a lot of you looked an awful lot like addicts who were being told their dealer was going to be unavailable for the next couple of hours. And, you know, a lot of us feel like that. And it might sound weird to say, oh, you know, I've been talking about how disconnection is a major driver of addiction. But weird to say it's growing because you think, well, we're the most connected society there's ever been, surely. But I increasingly began to think that the connections we have, we think we have, are like a kind of parody of human connection. If you have a crisis in your life, you'll notice something. It won't be your Twitter followers who come to sit with you. It won't be your Facebook friends who help you turn it round. It'll be your flesh and blood friends who you have deep and nuanced and textured face-to-face relationships with. And I think there's a study I learned about from Bill McKibben, the environmental writer, I think tells us a lot about this. It looked at the number of close friends the average American believes they can call on in a crisis. That number has been declining steadily since the 1950s. The amount of floor space an individual has in their home has been steadily increasing. And I think that's like a metaphor for the choice we've made as a culture, right? We've traded floor space for friends, we've traded stuff for connections, and the result is that we are one of the loneliest societies there has ever been. And yet, Bruce Alexander, the guy who did the Rat Park experiment, says, we talk all the time in addiction about individual recovery, and it's right to talk about that, but we need to talk much more about social recovery. Something's gone wrong with us, not just as individuals, but as a group, and we created a society where, for a lot of us, life looks a whole lot more like that isolated cage and a whole lot less like Rat Park. But if I'm honest, this isn't why I went into it, right? I didn't go in to discover the political stuff, the social stuff. I wanted to know how to help the people I love. And when I came back from this long journey and I'd learned all this, I looked at the addicts in my life, and if you're really candid, it's hard loving an addict, and there's going to be lots of people who know in this room you're angry a lot of the time. And I think one of the reasons why this debate is so charged is because it runs through the heart of each of us, right? Everyone has a bit of them that looks at an addict and thinks, I wish someone would just stop you. And the kind of script we're told for how to deal with the addicts in our lives is typified by, I think, by the reality show Intervention. If you guys haven't seen it, I think everything in our lives is typified by reality TV, but that's another TED Talk. If you've never seen the show Intervention, it's a pretty simple premise. You get an addict, all the people in their life, gather them together, and say, if you don't shape up, confront them with what they're doing, and they say, if you don't shape up, we're going to cut you off, right? So what they do is they take the connection to the addict and they threaten it. They make it contingent on the addict behaving the way they want. And I began to see why that approach doesn't work. And I began to think that almost that's like the importing of the logic of the drug war into our private lives. So I was thinking, well, how can I be Portuguese, right? And what I try to do now, and I can't tell you I do it consistently, and I can't tell you it's easy, is to say to the addicts in my life that I want to deepen the connection with them, to say to them, I love you whether you're using or you're not. I love you whatever state you're in, and if you need me, I'll come and sit with you, because I love you and I don't want you to be alone or to feel alone. And I think the core of that message, you're not alone, we love you, has to be at every level of how we respond to addicts, socially, politically, and individually. For 100 years now, we've been singing war songs about addicts. I think all along we should have been singing love songs to them, because the opposite of addiction is not sobriety. The opposite of addiction is connection. Thank you.
I think largely the video was obviously born out of passion and a sense of connectedness to people with a lived experience of addictions. And although broadly he's spoken about substance misuse and substance dependence, I think it's fair to say that, he was clear that the issue of connection was a substantial one for people with all kind of sort of addictive behaviours or addictions, that it was somehow meeting a need. And I think that's a really important factor to think about. We are hardwired to connect. We are social creatures, and where that need doesn't happen for a various reasons, I think that there's an unmet need. I always find it quite helpful to kind of reflect on people's lived experiences, their behaviours, and the difficulties as meaningful. They're meaningful experiences that are trying to tell us something. And I wonder, how useful that video was in kind of illustrating that and thinking about what needs are being met by addictions. That the kind of change in drug policy in Portugal has really robustly begun to address. I'm going to move us on from that to thinking about our own experience of working with people who have these diagnoses. And, it was very clear from the outset that there is a kind of common theme around the concepts that come to mind around working with people who attract these diagnoses. But I'm wondering if we can't get some kind of discussion or chat going that gives me some indication about what your experience has been working with people who attract this diagnosis, what the kind of difficulties are that are being presented. Are there similarities and differences if you've worked with people with personality disorder and or addictions? And why do we think that quite often what we'll see in a practice setting is that people who attract a diagnosis of personality disorder also highly likely to demonstrate behaviours that would be consistent with addiction? So it'd be really interesting just to spend a few moments getting some interaction in respect of that. I think there's some interesting points being raised around the kind of ecological factors that might influence certainly the experience of that might kind of illustrate these kind of diagnoses, looking at how society responds to deviations from what's considered as normal. I think it's an interesting point when we think about how both societies structured that might influence the onset of some of these difficulties, but also how it then goes on to maintain it. And I think that the change in public policy and legislation around substances in Portugal is a really good illustration of that actually the impact on the kind of prevalence of addictions has dropped quite significantly. So thinking about ways in which we engage people differently is really, really important. And I think, many of you have kind of identified that addictions are often a way of coping with difficult feelings. And I'd say for some people that's true. But I also agree with the narrative that actually sometimes it's about connection. It's about not having a way or not knowing a way of connecting with other people. And when we think about both of those kind of diagnoses, quite often they engender in people repulsion and disgust and resistance. I think that by virtue of that presentation, people are often much more arm's length. They do deviate from what we would expect as a societal norm, for want of a better term, and are pathologised because of it. that we have different expectations around alcohol use than we do heroin use, for example. Quite often we don't consider addictions of other sorts, like sexual addictions, or how addiction might fit, for example, in people who have eating disorders, that there's a level of compulsion and addiction prevalent there. I think it's interesting to think about addiction as a lack of control. I think sometimes it's in an attempt to control their existence, or an attempt to connect. It's, in many respects, a remedy to a problem, although a personally costly one. So I think it's interesting that we're beginning to think about that. I think the difficulties that are kind of being highlighted around inconsistency, sporadic attendance, difficult to engage, on reflection, some of that we might think about how we're measuring those difficulties in relation to our own professionalism. How good am I as a social worker if this person never attends? How does that affect how I feel? About myself as a practitioner and doing the job. The reality is that the interpersonal nature of working with people both with addictions and with personality disorder is a real challenge, because there is no clear kind of treatment pathway in many respects. There's no medication to treat or cure these conditions. And much of it is grounded in that kind of relationship-based practice. And when people present with distress, or in ways that can be quite rejecting or quite difficult, it is, I think, it makes it more of a challenge for us to embark upon that. Again, there's no immediate change. And when there is change, quite often those can be quite short-lived, and our experience is then a frustration in response to kind of engaging with that population can be quite difficult. I just wanted us to kind of think about it from the other side of the fence in many respects, and to have a think about a kind of service user, a lived experience account of what it might be like to live with these experiences, and how they make sense of those. And I guess that really leads us on to thinking about how much of this relationship development, this personality development, the sense of self, this need to connect with other people, how our childhood and our early experiences have influenced that trajectory, and links quite well into thinking about some of the work done by the Adverse Childhood Experience Study in the US. The Adverse Childhood Experience Study was originally undertaken by Folletti et al. In the US, was a large longitudinal study that looked at specific measures of a childhood adversity. And I'll give you a little bit more detail about those from the outset. But what he found was that the greater number of adverse childhood experience measured in childhood had quite significant outcomes for mental health and well-being, and not just mental health and well-being, interestingly, in terms of health overall. So people were much more likely to go on to have chronic health conditions, cancer, diabetes, to have premature death, with greater numbers of adverse childhood experiences. And this study's been replicated in smaller studies in the UK, which has been interesting. But again, the results are synergistic. They are suggesting that there's quite a high correlation between adverse childhood experiences and the onset of health problems. In terms of the adverse childhood experiences, what is currently measured are things like experiences of childhood abuse, physical, verbal, and sexual, the impact of parental separation or parental mental illness, experiences of domestic violence in the home, witnessing domestic violence, emotional and physical neglect, parental substance use, and loss or disconnection from parents due to incarceration. And it was interesting to find that the more ACEs, adverse childhood experiences, a person had, the greater the risk was for the onset of disease and disorder. And this is a really interesting study and worth considering. I think there's been further discussion or discourse around the impact of adverse childhood experiences, not just in relation to these, but in relation to where you are in a social structure, because I think those things are quite influential as well. You know, that there might be discrimination and prejudice that you already experience that provide additional layers and, you know, are additionally stressful. One of the things that the ACE study really kind of talked to us about, I guess, is the impact of those high stress states, particularly early on, and how those have now been linked to trauma experiences. And trauma, I guess, historically has always been considered in respect of big T traumas like war. But these perhaps are smaller T traumas, and that's not to say that they're less significant traumas, but they're not large scale traumatic events, and perhaps are discrete or individual or cumulative events that happen over a period of time. And those events shake your sense of self or violate your sense of safety in the world. And I think that that's quite important to think about. I also think it's quite important for us to think about this in relation to the stress response, the kind of fight, flight, freeze response that's triggered when we're under intense stress, and what might be happening if that response is triggered sequentially, you know, or if it's pretty consistent. If we're living in this hyper-vigilant, hyper-aroused state, particularly early on when we think about the way that a child develops. You know, our brain development isn't bilateral. It's you know, it happens progressively over time. If our trauma experiences are happening during times of particular development, what is the implication for that? And I think it's really important for us to pay this some mind, particularly in relation to these sorts of presentations. When we think about the impact of adverse childhood experiences, it's really, really well documented, the links between adverse childhood experiences and the onset of mental distress and mental illness. And I think that those of you who work in children's services will be able to think about that in terms of first-hand thinking about a child's lived experience of adversity, and perhaps even think about the impacts then of parenting practices. You know, if you've had traumatic parenting, if you've got no, I guess, basis at which you can found your parenting, good parenting or good enough parenting on, there is no place to start. But also thinking about that in relation to emotional regulation, you know, being able to mentalize and hold somebody else's experiences in mind, and how that these experiences can often replicate themselves through generations and in relationships. And again, as we started this webinar, we started talking about the interpersonal nature of some of these difficulties, and perhaps that's the kind of common theme that we might think about. So in relation to ACEs and addictions, what we do know is that women were more likely than men to have experienced 5 or more adverse childhood experiences, and that those higher ACE scores were correlated directly with higher levels of addiction to alcohol and drugs in adulthood. So the rates for adverse childhood experiences and the risk for adult alcoholism is substantial, as is the risk for intravenous drug use in men. In terms of on a percentage level, the percentage of IV drug use in women can be kind of directly correlated to adverse childhood experiences. And that's worrying. There's also some discussion around the increase connection between personality disorder and addictions, particularly alcohol dependence, which is probably one of the more common addictions that you're liable to see. So the link between the adverse childhood experiences or trauma, if you want, with personality disorder is quite well documented. There's been lots of discussion over a long period of time around the connection between early trauma experiences and borderline personality disorder particularly, although there isn't really a good rationale for why borderline in particular is more a focus. I think universally those diagnoses of personality disorder are quite well correlated to adverse childhood experiences of one sort or another. And there's lots of discussions around whether personality disorders should be seen within the kind of context of a trauma spectrum disorder or a complex post-traumatic stress disorder. And I think thinking about that in relation to relationships, I quite like this particular quote. Individuals who have experienced insecure attachment are at risk of developing disorganized affective systems. Thinking about the role of attachment, that early relationship whereby attunement is possible, whereby you have a sense of emotional containment with your primary caregiver, and what happens when that's not available or that's compromised. And I'm not necessarily talking about mother and child attachment, although that's very well recorded and documented by Ainsworth and Bowlby. But a primary caregiver of any sort, quite often you'll be thinking about risk and protective factors, and when that bio-psychosocial component, having a parent or a caregiver who is available to a child to offer attunement and some emotional containment is really important. But what I'm really interested in terms of attachment and attunement really is the role of shame. I think shame is such an interesting component, and I think when we think about our experiences of personality and personality disorder and addiction, often those ideas, those concepts about being antisocial or not complying are kind of quite steeped in shame, that they're somehow not fulfilling their obligation, that they're somehow inherently bad. And I think that those things are quite interesting. Dan Hughes talks quite a bit about the shield of shame, and what he suggests is that shame is part of a normal human development in childhood, and actually when we are growing up as small children, part of our healthy development is that we experience shame, but in the context of a safe, loving relationship with a primary caregiver, we're able to reconcile that shame. And so the shame we don't internalize it. We're not bad, but the thing that we've done is bad. So we have caregivers that offer us responsive care, and they apply boundaries which are healthy. And in doing so, they don't disconnect from us. So they will, identify that something that we've done is wrong, but they will immediately go to repair that relationship. And in that repair, we recognize that we're able to manage our shame. We're not shameful as people, but we are we're learning something new. That kind of social learning. But if that repair to the rupture in the relationship isn't forthcoming, then we can internalize those experiences. And around the age of 2.5, children start to develop a sense of guilt, and the guilt is the driving force for them wanting to repair that relationship. So I think it's interesting to think about how we think about the role of shame in our ability to make sense of our behavior and our behavior with others, and how if we don't have that repair, that interactive repair, then we're unlikely to be able to manage our feelings of shame and humiliation, and we therefore begin to act in ways that are antisocial or are angry because we're defending against that sense of shame. Much more is written about that than we have perhaps time to think about, but it's really worth having a look at Dan Hughes's Shield of Shame. I thought it would be useful to find out a bit about where you are located and what your experience is of working with children, with people with personality disorder or addictions. And the reason I think that is because obviously, your experiences are going to be quite different. From a children's social care perspective, I guess, those people with the diagnosis are often the parents or the caregivers, and it's about thinking about ways in which we can engage with parents who present often very challenging or difficult behaviours, who are perhaps reluctant to engage with services, and quite frankly have quite a lot to lose in the process. And from my own practice experience in children's services, knowing that it can be quite difficult to engage with parents who present with quite poor emotional regulation, who find it difficult to hear the challenge about concerns about their ability to deliver care. And equally, having worked in adult services, helping people make sense of how their behaviour and how their distress can represent a challenge in order to develop that relationship. I think from my perspective in social work, largely social work is relationship based, and that can be quite the trick with working with people who have these difficulties, if the nature of the difficulties is interpersonal, and often also the origins of the problem are interpersonal. If we think about the origins of the difficulties being in those early relationships or in those trauma experiences, those very people who were meant to keep us safe were unable to do so. And I'm wondering what the difficulties might be for them in terms of trusting us enough to engage.
There's this really interesting flowchart I thought might be useful to think about, and it kind of gives us some illustration of the difficult patient. One of the ideas being that some of those behaviours that we've identified around personality disorder and addictions, and the kind of moral cause versus the social cause or the biological cause, and how that might elicit different responses from practitioners and caregivers, and how it might also be strongly correlated with a sense of professional pessimism. We don't have necessarily a robust treatment to offer people. Their presentation is often difficult or distressing, and can often trigger in us our own irritations and responses to our own story. We all have buttons to be pressed, and when the relationship or much of the therapeutic work is grounded in the relationship we have with others, it can be quite difficult if the relationships we're having are difficult from the outset. I think there's an interesting point around working in child protection services and a mother with a co-occurring experience, and that the nature of the engagement was generally unpredictable, and that largely the motivation to kind of engage in any treatment was by coercion rather than by choice. And I think that's a very real experience. And I guess the trick in many respects is helping people understand where you're on the same page. I think for most part, parents don't want to be bad parents, but they don't know how to be good parents, perhaps. And that, in exploring with them, or kind of identifying that their motivation is in the right place, that you're coming from the same page, is often a good starting point. And that to assume in some respects that there is purpose behind the choices and decisions that they're making, even if it's perhaps not the right way of going about things. There is a purpose behind it, and helping people trying to consider the implications for their choices and behavior. And I guess that goes back to mentalizing, doesn't it? Being able to contain people's experiences in such a way that helps them make sense of them for themselves. And I think if you haven't had that to begin with, that can be a real challenge. Often I would suggest that, when working with people with high levels of distress, particularly people who are antisocial or have difficulties regulating their emotional experience, for me, being able to recognize that this is purposeful, this is purposeful behavior, that it is a communication is quite important. And I think being able to think about that in terms of what I bring to the table as well as what the service user brings is quite significant. I think it's hard to think about our interactions in relation to service users and to think about what it is that we bring, and that the kind of process of reflection, of understanding my experiences, what my anxieties are, why this is a worry for me, the nature of the kind of help-seeking behaviours being risky or kind of a challenge for professionals to cope with. What is the fear in you that's driving it, and how can that be managed? being able to get kind of support where you can, and recognizing that, you know, often when people present with challenging behaviors, that can cause some division amongst professionals. One of you raised a really interesting point around language, and I think language is really important. Language is a conveyor of meaning, and whether you intend it to be so or not, it gives implicit as well as explicit messages to others. And I think if you're traumatized and you're hyper aroused, if we go back to that autonomic nervous system response, and you are, you know, you're sensitive to what's going on around you and the interactions of other people, then that is even more important, that you're able to be mindful of the language, because language can provoke quite difficult responses. But it also says something about what we intend, what we mean, and I think it's really important that we're mindful that that we're not inadvertently giving people messages that are perhaps not consistent with kind of anti-oppressive or anti-discriminatory practice, that we're not inadvertently disempowering people. I think, you know, it is interesting to think about the complication of kind of supporting people with both co-occurring personality difficulties and also addictions, because ultimately, in many respects, some of the thinking is that the origins are the same. The manifestations of the problem may be different, but the origins perhaps are similar, that people are needing to connect and not having the capacity to do that. And I think by framing our thinking around particular behaviours in that respect, we also enable people we give people a much more compassionate response. Going back to thinking about that flowchart and the kind of origins of the problem that we're identifying with, the meaning that we're attributing to people's behaviour has a huge impact on how we're able to engage with them. You know, quite often we can kind of feel hopeless and dejected by those kind of presentations. And I think that in order to kind of work more effectively, we need to kind of be thinking about why is it that we're feeling the way that we're feeling about these presentations? What is it in us? And why is it different amongst us and our colleagues, perhaps? I thought this would be a good place to have a bit of a discussion. It's kind of synergistic with much of what we've been saying, and it's been said before. So this was adapted from Watson Morgan in 1994. So we've been having the same conversation and same experience of supporting people with both personality disorders and addictions, because, you know, they do present quite often with distress, but also rule violation behaviour. And so we're kind of conflicted quite often as to whether we're meant to be being authoritarian, or nurturing. And it, you know, quite often the presentation can change quite rapidly. And, you know, so our responses to that change quite quickly. I think one of the kind of significant frustrations is in terms of treatment, in terms of treating both addictions or personality disorder. There's no single medication to kind of make this better, or one single kind of treatment program that works for all people. And whilst I'm not in any way suggesting that people with other mental disorders or mental health problems have one universal treatment. There is a general kind of consensus that there is a particular type of medication, something that would work quite rapidly to alleviate some of the symptoms. But with these particular presentations, that's not likely. And whilst there are medications used to treat some of the symptoms, either of anxiety or of low mood, or to address withdrawal symptoms, or to facilitate detox, largely these are not what treats the condition. There's no cure. And I think that can present with some challenge. I'm invited us to think about self-harm here, because self-harm and risk are kind of synergistic with both substance use and quite often with people with personality disorder. And for some people, substance use or addictive behaviours are risk-taking behaviours. They are acts in some aspects of self-harm, whether that's that you're using substances in risky ways, or engaging in addictive behaviours, sexual addiction being one, whereby you're taking inadvertent risks that put your health and in some instances your life at risk. So I think it's quite interesting to think about this, and I certainly think this would be one of the challenges of practice. And again, thinking about self-harm in its context, I think certainly with respect of addictive behaviours or addictions, drug use by its virtue can result in a lot of kind of risk-taking behaviours, and in some respects, when we think about that in relation to drug tolerance or alcohol tolerance, there is a kind of natural kind of progression to push the limits of use to get the same effects of substances, knowing that each time you do so, you may put yourself at risk. But thinking about self-harm and relief of tension, of kind of intrapsychic pain, Schneidman talks about psych ache when he talks about suicidality, and I think this is a really interesting term. It's almost like an unbearable psychological pain, and he describes that as one of the kind of primary factors in people ending their life by suicide. But I think there's been some synergy with that in relation to acts of self-harm and varying degrees of self-harm. And I guess I'm wondering around whether or not people's experience of self-harm is a way of managing those kind of psychological pains, or whether or not it's a communication. Certainly in my experience working with people, there have been times where people have self-harmed and wanted to show you the damage they've caused themselves. And as a practitioner, that can be quite distressing and confronting. But being able to be curious about what is it you want me to hear from this experiences, what is it that you're wanting to tell me? Is it a cry for help, or a kind of request for a connection, wanting to connect to somebody somehow, and not having a mechanism to do so? Or is it perhaps for some people an issue of control, when things feel overwhelming and you feel out of control, that you can manage that experience in a very practical way? So it's interesting to think about that in relation to your thoughts. Many of the characteristics we've spoken about this far have a very clear interpersonal element to them. And for that reason, working with this particular group represents a number of challenges. challenges in terms of us building those therapeutic relationships and maintaining them. And there are a kind of range of challenges that these kind of interpersonal elements have for us in terms of our ability to communicate. And I know that we've talked about language being important, but also, how we're how we're facilitating communication. When we look at the issues of self-harm, whether or not those are communications in themselves, how we set the boundaries in the relationship. And I think boundaries in relationships are important generally, but how we stop ourselves from becoming over-involved or under-involved, and how do we know, how do we keep a check on that? How do we know where we're at? How do we stop dependency issues? And when I talk about that, I don't mean dependency in terms of substance, but I mean dependency on service provision. How are we enabling people rather than disabling them? Quite often people with who attract that diagnosis of personality disorder will have quite high expectations of services. And I think largely that's that's as a result of having been disappointed, and having an organisation that's committed to caring for you. You have often quite unrealistic expectations about what that can deliver. But also our expectations, our expectations about what we expect from the service user, how they get to their appointments, whether they turn up or don't turn up, what we expect for them in terms of the tasks that we expect them to do, or the level of awareness we expect them to have. And in terms of emotional responses, both theirs and ours. I think working with people on an interpersonal level, when we're thinking about connecting with others, managing this kind of unpredictable scenario where there's lots of high emotions, can be particularly difficult for us to manage as practitioners, but also for service users. And I think quite often we have to be mindful that we're not slipping into punitive role where we're kind of punishing bad behaviour, for want of a better term, and that we're able to be mindful of our own emotional responses. With any relationship, it's about thinking about the purpose of the relationship, being able to develop a safe relationship that's boundaried and where there's enough warmth and it's safe is really important. I think it's very important if we consider that both diagnoses generally are highly likely to have had unsafe relationships or unsafe experiences in their childhood, and that we are able to offer these relationships kind of congruent with the kind of role that we have and our duty of care, and that the interventions and the engagement that we're having is effective, and that we're helping the service user develop skills perhaps that kind of promote functional coping, and that are empowering. And that can take a lot of time. Some of the literature around recovery-oriented practices talks about what makes a good therapeutic relationship, and one of the fundamental things that was identified was being able to retain hope even when things were really difficult, and being open and honest and transparent. And I think about that in relation to the kind of trauma experiences that perhaps people might have had, and their need for safety and consistency. So our therapeutic relationship has to be warm. I think the use of reflective listening is really important. When we're able to mentalize for the person and we're able to assist them, contain them enough to make sense of their experiences, I think that's really useful. There's lots of literature that talks about the transformational effect of a therapeutic relationship for people who have both addictions and or personality difficulties. It's almost a process of relearning. So assisting them to make sense of their experiences in a way that they haven't had the opportunity to in previous relationships. And that can be really difficult. And that means we need to be able to tolerate some of those difficult emotions, and we need to get support in doing so. And we need to be able to work in a person-centered way that thinks about the needs of the organisation, the role and structure in which we're operating, but has some flexibility in terms of our approach to the service user, in that it's kind of person-centered. That the relationship is a safe one where there are boundaries and we know what those boundaries are, that there's a good degree of honesty and openness, that we're mindful of the language that we use, and that we're consistent in our approach, and that we continue to engage even when we're being told we're not wanted. You know, one of the literature around recovery-oriented practice that came out of South Australia, I think, talks a lot about, you know, the ability to be present and to hold that hope. And Pat Deegan in her works talks quite a bit about her own experiences of having had a psychosis, and one of her stories illustrates the kind of hope that was provided to her, and the consistency and the level of care offered to her by her grandmother, whom at the time she described being quite unwell and being quite withdrawn. And she said the thing that was most transformational for her in her recovery journey was being able to have her grandmother come in and ask her every day if she wanted to go to the shop. And every day she would reject her grandmother's request. This went on for some months. And then one day her grandmother came in and she agreed to go. And she said the fact that her grandmother had never given up on her and still kept coming back consistently, offering the same level of support, that unconditional positive regard the whole time was what pulled her through. Eventually, she was kind of much more active in her own life. And I think it's about being responsive, being able to sit with somebody even when they are distressed and even when they don't appear to be motivated. One of the things that I think is quite important is to think about active and inactive spaces. And when I talk about active and inactive spaces, I'm talking about, you know, quite often we're quite positive about people when they're doing something, when they seem to be doing the things that we're asking them to do, because they're active in their kind of recovery or in their engagement with service providers. But I'd invite us to think about those inactive spaces, because even when we're not active, when we're not actually physically doing something, in our minds we are active. And those inactive spaces often are a space for people to start to make sense of their experiences, even if they're not actively doing something just yet. So I think it's really important to kind of hold that in mind, that sometimes it takes people a bit longer. But just because they're not doing something, it doesn't mean they're not thinking about how they can go about doing it. There are a range of therapies aimed at working with, particularly with personality disorder, but also with addictions. And, you know, there are advantages to each of these. I think from a trauma-informed perspective, however, we often we often talk about cognition and thinking about things, but I think that's perhaps not the first place to start. And you may disagree, and we'll have a think a bit more about that later on. I think when we think about the interactions between service users, us, the staff, and the needs of the organisation, as well as the kind of social and political climate at which we're existing, we know that we're in a time where there's less resources available to us, that we're expected to do more with less, that people are subject to complex disadvantage, perhaps not having their basic needs met, greater numbers of homelessness. What is the impact of that on our delivery to provide safe and responsive care? And Bloom had a point that he wanted to make, and I thought, thinking about that in relation to the ecological influences that impact on these particular service users, what are the ecological factors that might influence, help or hinder engagement or work with them? Because actually this particular population in many respects are those considered harder to treat. There isn't a particular provision dedicated or a particular medication. Psychological interventions cost much more money than medication, take much more time. What is the impact of that in terms of our morale in engaging with these service users, but also in terms of what we have available to offer them? And with that in mind, I think we need to be mindful that sometimes we inadvertently re-traumatize people with trauma experiences in our approaches, and I don't mean that as individual practitioners necessarily, but also in terms of the way that the system's structured to support people. When we think about working with addiction and thinking that that actually people can't be trusted or aren't able to tell the truth, what are we telling them about themselves? Thinking about language like non-compliance kind of reinforces that internalized shame about being bad or not good enough again. And I think that those are really important things that we need to hold on to. That kind of expertise that we often will overlay in a therapeutic interaction about our body of knowledge being more significant or more powerful than the wisdom of the lived experiences is quite disabling and can be quite difficult. So we've talked about the therapeutic relationship quite significantly, and the use of self. So I might move on to the next activity, which is thinking about our own reactions and emotions when working with this particular group, and how do we manage those reactions. I think about this particularly in relation to the fact that in interpersonal interactions we're often triggered by things that we find highly irritating or very difficult to manage, and whether or not we as containers of people's difficult emotional experiences are also experiencing some degree of containing by supervision or our service system. I think our own strong emotions of feeling kind of overwhelming sense of anxiety and kind of a degree of stress is very valid. And I think that often we hope that we have safe relationships within our workplace, that we're able to make sense of those and kind of consider and explore why it is that we feel the levels of discomfort we do. with the individuals that we're working with, and what is it about how the risks or concerns that these people are presenting to us that are too difficult to manage. I think being able to sit with our own distress and with the distress of others is really important, because I think it's important to make sense of what it means, both for us and for them. Again, it is largely around a communication of sorts. There's a message to be understood by it, and it's about making sense of those messages. And providing people with, and ourselves, containment enough that we're able to establish our own emotional safety, so that we can process our experiences and that the service user can process theirs. In effect, to begin with, we are the emotional regulators for the service user's experiences, and in order to do that, we need to be able to to have some degree of containment. I think in many respects, trying to help people regulate their own emotions from the outset is quite important. So I guess it's starting from the point of what's happened to you, not what's wrong with you, and being kind to ourselves in that as well. I think thinking much more about how we view the nature of the problem as meaningful, and how we can make sense of that. I'm going to shimmy through a few slides if that's okay, because those will be available for you online, and I'm minded of the time. Just to talk about, there is some details on here around managing splitting, and I know that is almost certainly a concern for a lot of people. So that where I'm going to take us to for the moment is around the principles which we'll address, and then I think we'll move on to managing our own reactions, and we'll wrap up. So in terms of these principles, here are around trauma, based largely around trauma-informed approaches to working with people with these difficulties, and it is around creating trust and safety. Inherently, if you've been in if you've had a life where you've been where people have distrusted you, and that's been inherently unsafe, I think that's a very difficult place to kind of make any change. I think in order to take risks, we need to feel safe. And when I say take risks, I don't mean take the kinds of risks that perhaps they've already been taking, but taking the risks to be different or to be vulnerable enough to kind of reconcile some of the difficulties they've had. And I think if you've come from a place where safety isn't a thing, then I think it's really important that we're able to help people by creating a safe enough environment and relationship for people to proceed. And that means being, operating with quite a lot of openness and honesty, being able to be consistent and being supportive, empowering people to make choices, to be collaborative where you can, trying to understand the experience without judging what it means. So being much more curious and being able to maintain that empathic position even when it's really difficult. And whilst doing all of that, what we're asking you to do in many respects is being authentic to yourself, which can be difficult when you're struggling. So being authentic but not rigid, and being aware of yourself and what you're feeling and how you may be responding to some of your own emotional responses in that. I think it really is starting from a place of building a relationship and assuming that people are I guess prepared to take the risk with you, that actually they are you can be hopeful that they can make the changes, and that the behaviours that they're presenting with are purposeful and meaningful experiences. And I think for us, it's about managing boundaries in those relationships to keep ourselves safe, so that we're not feeling stuck or paralyzed. If we're not able to access the right support and supervision, that we're able to go out and get that. And that, that's possible. And certainly in my own professional career, where I've struggled with supervision, that's something that I've sought out for myself, because it is hard to work with a population where you don't have necessarily resources or tools to enable the kinds of change that you're hoping for. And also being able to adjust your own expectations about what is the change that we're asking people to make, and where should the start point be. Being able to manage the boundaries in the relationship and keeping ourselves safe, being compassionate and demonstrating warmth, but not being responsible for the decisions that they make. We have a process of accountability, yes, and we're making informed decisions which we're documented, and we're supporting people to make safer choices. We need to recognize our own limits, and we need to be the ones in control of the boundaries. Because if you're a person who's had difficult relationships, and hasn't had a sense of boundaried relationships, safe and boundaried relationships, then people are not necessarily going to know where to start. And I think, being able to set up safe relationships where everyone knows what's expected of everyone, that there's a non-blaming style, that you're engaging with warmth and you're saying, this is the parameters of the work that we have here to do. I think that's really important. The last point I want to make is around managing our own reactions. I know that the nature of the job is personally quite taxing, but we need to become much more aware of our own thoughts and feelings and our own physical responses, so that we can kind of ensure that we're not bleeding into an interaction, and we're not responding to people based on those interactions, but also that we're able to look after ourselves. Hearing people's trauma experiences is difficult to manage. And we want to make sure that we as practitioners are safe and well. So I think it's important that we do that. The one thing I think is really important in these kinds of interactions is that you're able to have some kind of discussion, whether that's in supervision or within your peer, to think through some of the difficult feelings that you're having when you're having them, so that you can better understand them and better respond to them in future. We've gone over time, so I am minded about that. There is some information and resources, and the slides as well as some other articles will be made available for you. I hope the discussion has been helpful, and I wish you all the best.